Without further ado, Dr. Rimawi is going to take us through. Thank you, Dr. Rimawi. Thank you.
I think Michelina, prepared the atmosphere for us with her talk and the discussion. So here are my disclosures. I leave them for more than 1 second. People flash them and to move on. This is where usually my HER2 pathway slide goes. And that's been usually a slide that I kept in all my talks for more than 20 years. And then I decided that people are tired of it and I'm going to change it. And of course, the first thing that Jason tells me when he saw my slides, where is your famous pathway slide? So it's going to come back next time. But good. I think we all agree that targeting HER2 has been one of the most important advances in not only clinical breast cancer management, but probably in clinical oncology. Since the pathway was discovered as having a poor prognosis, reported by Dennis Lehman and Bill McGuire, and then after that, the development of trastuzumab and all the different improvements along the past 30 years has really transformed the way we think of this disease. I was speaking to a reporter today, and I said, we used to actually think HER2, I'm worried about the patient who has HER2. I'm not worried about them today, but I'm a lot less worried than I used to be about them when I started. So, in the metastatic setting, the standard was set by the late Jose Baselga in his presentation of CLEOPATRA trial in San Antonio about 13 and a half years ago. And basically that trial randomized patients to the standard of care established about 10 or 12 years before by Slayman, which is essentially trastuzumab plus taxane versus the addition of pertuzumab. And that trial, when Dr. Baselga presented it, was interrupted with applause when people saw the magnitude of improvement. And this was the final analysis presented by Sandy Swain that showed really an improvement of 16 months in overall survival. After this, we started telling a metastatic HER2-positive breast cancer, the average patient with your disease lives for 5 years. That's not something we used to be able to say when I was in training. And that remained to be the standard of care. Maybe, the PERTAIN trial that we did kind of helped establish the inhibition of ER and HER2 together as a standard. And then fast forward until 2025, when the PATINA trial, which is now published, was presented by Otto Metzger. And that trial took the patients who were already underwent induction treatment with a CLEOPATRA regimen and then randomized them into receiving trastuzumab, pertuzumab, and endocrine therapy with or without receiving the addition of palbociclib. The idea was a more thorough and deep inhibition of the ER signaling axis to see if that crosstalk could be inhibited more efficiently. And it worked. Remember now that this PFS is from the time the patient enrolled, which is after induction. So this does not account for the patients 3 to 5% who might have progressed during induction. And the trial showed a remarkable improvement in PFS, 29 versus 44 months, and really a p-value with enough zeros to impress all of us. And then, of course, as if that was not enough good news, 6 months later, the results of the DESTINY-Breast09 trial were presented by Sarah Tolaney, and essentially the trial took the CLEOPATRA regimen and challenged it with 2 T-DXd-based regimen, 1 T-DXd plus placebo and 1 T-DXd plus pertuzumab. This trial reported an interim analysis, and at the interim analysis, only the arm that crosses the boundary would be reported. So as of this date, T-DXd plus placebo is still blinded because it's not reported yet, but the T-DXd plus pertuzumab arm is reported. And here's that. I think you've seen this curve. Very impressive THP at 27 months, and the T-DXd plus P at 40.7 months. Hazard ratio of 0.56 and a bunch of zeros in front of that p-value. And look at the 24 months. So at 2 years, there was an 18%, almost 20% difference in progression-free survival. This is really a remarkable improvement, undeniable improvement in in PFS, of course. You look at the forest plot, the subgroup analysis, it didn't matter if the disease was de novo recurrent, didn't matter if it was hormone receptor positive or negative, it didn't matter if PIK3CA was mutated or not. We know that we published and others did that PIK3CA mutation is associated with resistance to anti-HER2 therapy, particularly naked anti-HER2 therapy, not the case here because of the antibody, and anything else you can look at. Trust me when I say T-DXd plus P seems to have worked for all those subgroups. Recently at ASCO, one of my colleagues, Dr. Park, presented some data on response groups in T-DXd plus P per arm. And I want to say two things here. One is that the complete responders and what they called deep partial responses, which is a shrinkage of more than 80%, really did better than those who did not respond very well, which kind of makes sense when we say a patient to T-DXd not responding, we know they're not gonna do very well. And so that's impressive. The other thing is the median time to achieving best response was about 8 to 10 months. So the T-DXd continued to work for 8 to 9 months, while on the chemotherapy arm, as expected, they achieved the best response by 5.5 months. So this is something to keep in mind as we think how we're going to utilize this strategy long term. And then a third bit of good news came to just mix up the field a little more and confuse all of us if we're not confused enough. So HER2CLIMB-05 was reported in San Antonio by Erica Hamilton, recently published, and it really optimized HER2 inhibition and by the addition of tucatinib to the maintenance regimen. So think the same way as PATINA, patients who underwent induction, they were enrolled, whether they were ER positive or negative, and essentially the only criteria was adding tucatinib versus not to HP. Endocrine therapy was allowed but not required for the ER positive, HER2 positive group, which I think is a travesty because it really confounded, in my opinion, the results of the trial. However, the trial was quite positive, 25 months versus 16 months, a hazard ratio of 0.65, a lot of zeros in front of that. The difference was 8.6 months. I think because T-DXd has spoiled all of us and ruined our perception of improvement in benefit, people were like, oh, only 9 months. We used to celebrate 3 and 4 months. So just to put it in perspective, this was a very respectable improvement. If you looked in the ER negative subgroup, you saw a very robust improvement. The hazard ratio is 0.55, more than a year improvement in PFS. In the ER positive, HER2 positive group, the benefit was 7 months. Still respectable, but not as much. And I think some of this has to do with the fact that less than half of those patients receive endocrine therapy, and therefore, they did not receive the same benefit they could have had they all gotten it. Never to neglect, of course, that everything comes with a price, including magic. And so T-DXd plus P was associated with the 12% rate of ILD pneumonitis, and essentially, which is what we've seen in other studies. There were 2 treatment-related deaths in this trial. So any drug, regardless how important, how good it is, and how safe it is, by the way, it can really result in a very serious toxicity. So let's not get too comfortable with those serious drugs. In the HER2CLIMB-05 study, the only thing I want to say here is that I was a little surprised, though not alarmed, but surprised at the rate of transaminitis that we've seen with the addition of tucatinib. Some of it, grade 3. Again, does not make me not want to give the drug, but again, just highlights that we think of tucatinib as kind of a TKI, highly benign, and just important to keep an eye on these things because in these cases you stop the medicine, liver probably recovers, but you don't want to neglect that and then end up with more serious complications. And everyone says, okay, you're adding those treatments, and then what is the price you pay in terms of the patient-reported outcomes? Because everyone knows, the physicians in this room know, that we are not good at reporting AEs. We tend to focus on what we think is important. Maybe we don't do as good a job of trying to ask the patients the right questions. So the PATINA trial and the DESTINY-Breast09 had robust PROs. Of course, they used slightly different tools, but PATINA showed really that there is really no major difference in the physical well-being, functional well-being, global health, and functional status indicators between palbociclib and the standard of care in any way that would make any of us feel uncomfortable adding palbociclib to the regimen. DESTINY-Breast09 actually reached a similar conclusion. The time to deterioration in pain, was no different. The overall well-being, the global TTI was the same between the two groups. T-DXd arms had more constipation because of the anti-nausea we give, had more nausea, but it did actually have lower arm symptoms, lower pain, and other quality of life measures. And it made me think that T-DXd does have more toxicity than HP. There's no denying that. But it also, if it is more active against the disease, it may be lowering some of the disease burden symptoms, and therefore that washes off maybe in the overall well-being scores. Having said that, we need to look, this was an interim look, we need to look long-term and look at the T-DXd arm when it reports. And the last bit, I'm just going to tell you about the NCCN's take on things and my personal opinion. The NCCN guidelines said that the CLEOPATRA regimen remains the preferred regimen, and that the addition they did is that if the patients had tumors that also express the hormone receptors, to add palbociclib to the endocrine therapy and HP. After the FDA approval of the DB09 regimen, they added that as other recommended, which means it's okay to use it. Your insurance would approve it for the patients, but it didn't put it side by side by preferred. Now, why they chose to not put it there, it's, of course, their prerogative. I was not advocating, I did not expect that they would remove CLEOPATRA from the front line, but I did not expect that they would keep it in the preferred status and put that in. Of course, there's probably good rationale. We'll hear about it later. But here's my take on things. I think the management, it goes without saying, the management of HER2-positive metastatic breast cancer is rapidly evolving more than 13 years after CLEOPATRA rocked our world. T-DXd plus P, needless to say, is highly effective and induces deep and lasting responses. Even in DB09, when actually we knew that, in some cases, half the time the disease, the treatment was delayed or held, the responses persisted. We have strategies that optimized targeting of ER/HER2 crosstalk, like PATINA, of the HER2 inhibition, like HER2CLIMB, that resulted in improved outcomes. How do we use those is important. And how do we select the best regimen for each patient? I will argue, and we can discuss maybe during the networking hour, that the clinical presentation, the disease burden, the patient's comorbidity, the presence of CNS disease versus not at the time of presentation, patient preference, the patient needs to be at the heart of the conversation, are all factors from a clinical perspective. And then I can't help but wonder how biology might affect that. We need to think of the molecular profile. Are the patients whose tumors harbor a PIK3CA mutation more likely to be resistant to a naked biologic regimen than an ADC? For example, does ESR1 mutation, which we actually have seen, and it is being reported in increasing incidence with HER2-positive disease as well, is that going to herald resistance? And of course, HER2 mutations, are they also going to herald resistance to tucatinib, for example? And then should you want to consider those as you select your treatment? That is, of course, requires a lot of discussion. And of course, my usual disclaimers that we really need studies that can actually help us discern, some of those questions and answer them. And if Dr. Al-Kanani gets his study opened up soon enough, we'll be able to answer it. No pressure, Ahmed. And with that, thank you very much for the invitation.
Fantastic presentation. I'm going to start with the first question. So, you know, the CLEOPATRA was never designed to be an induction maintenance.
Absolutely.
But we got used to it. And we actually love it because we feel for our patient when you tell them, I'm going to put you on this treatment until further notice. In the majority of metastatic setting, except HER2 positive, we tell them we're going to induce you with chemotherapy, then we're going to maintain on biologics. And that makes them feel so much more at ease. And we've become accustomed to that. Now with T-DXd, pertuzumab, you're going to do it until further notice. Do you think there is a time where you can stop and start a maintenance strategy?
So, Jason, you know, I'm a big student of history. So if we want to go back to CLEOPATRA was about giving taxanes until you couldn't give them anymore. And the reason, and the protocol said you may drop them after 6 to 8 cycles, which was 6 months of treatment. And actually the reason that...
No endocrine therapy.
And no endocrine therapy, for sure.
Right?
Yes. And
no
then
endocrine therapy.
the reason that we dropped them is because the patients came with numb hands and feet.
Right.
So the patients and our clinical judgment decided when we stopped. There's nothing magical about 6 months or 6 cycles, right? So therefore, let's not get this as a dogma, okay? And I'm not saying we give T-DXd plus P forever, but who said that 6 cycles are the best way to go, unless there's a study. And, you know, we have Demether and we have other studies, and, you know, I picked on Dr. Al-Kanani because he's designing a study that hopefully will help us understand that. But we really need to think, how much can we give T-DXd before it gets bothersome toxicity? I want to be clear, I'm not talking about, you know, life-threatening toxicity. I'm talking about bothersome. We all know when the treatment is wearing out our patients. And, you know, is that 8 cycles? Is that 12 cycles? You know, we saw the data that the median response is 8 to 9 months, 8 to 10 months. You know, do we say, I'll get you to 8 months, I'll get you to 9 months, I'll try to get you to 6 months? I think we need to figure that out, is what I'm trying to say. And we owe it to our patients not to say 6 cycles is the magic number. It may be. But let's not, you know, we made up the 1 year of Herceptin. It turns out it was good. So maybe 6 cycles is the magic number, but let's figure it out. But in the meanwhile, I would say bothersome toxicity is what I would stop at if I decided to go with a T-DXd plus P. And then if I stopped, yes, I'm willing to switch to a
And would
strategy.
you do maintenance therapy? Because I think this is the big question, right? T-DXd induction, can you combine all of this data?
Like the
and do
PATINA, HER2CLIMB-05.
like maintenance after, because that's not what any of these studies aim to do, right?
For sure. And
would you do that?
For sure that, you know, we need studies to do that. In the interim, if the patient is ER positive, HER2 positive, and I want to switch them, and I think they can tolerate palbo, honestly, off-label, I will do it. If I think that they may not tolerate it, I'm worried about the toxicity, or we stopped because the patient was not doing very well and we don't want to replace one toxicity with the other, I might just do pH plus AI.
But a patient who's doing well on T-DXd induction, who has a great response, who has no nausea, you would continue indefinitely?
I would continue it until I feel that there is that the patient is starting to have toxicity that's interfering with their quality of life. But it doesn't have to be very bad, but I would not tie myself to 6 cycles. Now, if you said the patient continued to do great, would I continue it forever? I'll probably reconsider it if they had either a complete response or we got to about 8 months or so, which is about, you know, I think, 10 cycles? And then we're feeling, you know, and the patient is still without progression. Now, am I right in that? No, I just made that up based on the data that we have, but yeah, that's what I would do.
Perfect. Any questions?
But I wouldn't routinely switch from a T-DXd plus P into a PATINA or a HER2CLIMB, because then I'd be burning 2 lines in one.
It's going to impact their access to subsequent
Any questions
trials.
from our audience or from the panelists to Dr. Rimawi? All right, Ajit.
So how would you pick between the PATINA and the HER2CLIMB? maintenance strategy.
Okay, so let's say that let's say that we had a patient who had induction at, with a CLEOPATRA regimen to neutralize DB09. I think if they were ER positive, HER2 positive, I think no questions asked, I'd do PATINA. The reason for that is that study was designed for those patients and reported on those patients and had really good results. In the HER2CLIMB-05 study, unfortunately, it was not mandated. It was allowed but not mandated. They said it was different practice in different countries. And so I don't know that I would do that for them. If the patient was ER negative, HER2 positive, then I think tucatinib is probably the way to go. Where I would be worried about either one of those patients, or at least watch them very closely, is that if their tumors harbored a PIK3CA mutation, because we know these are early mutations, you can detect them at the patient's diagnosis or recurrence. I would just keep an eye on them because they may be one of the ones that progress a little faster.
Sorry, the ER negative, wouldn't you give them T-DXd up front? You wouldn't be in the situation of deciding about maintenance therapy.
Well, I was just assuming that the patient received the CLEOPATRA regimen and now they're seeing me for maintenance.
Okay, but if you're seeing them tomorrow for the first time.
If I see them tomorrow, then if they have really a heavy burden of disease and they have ER negative, HER2 positive disease, if they have a heavy burden of disease and I'm worried about them, I'm starting with the best regimen I have. Yes.
Perfect. All right.